she's going to be talking about. And we have this meeting recorded. So we have Dr. Safdar, who will be talking about the vaccine effectiveness domain team update. And then we have our monthly Recover Long COVID project updates. And Emily Pfaff and Richard Moffitt will be talking about that. Quick announcement. So this is our last meeting before we take a short break for the month of August, and we'll resume on September 12th, and we will after September 12th, and we'll stay tuned for the schedule for the upcoming community forum meetings. So we'll announce that in the next couple of weeks. On our dashboards, we have our 75 sites have now contributed data, and we've hit the 15 million patients in our N3C enclave with approximately 5.8 million COVID plus cases. And without further ado, I'm going to actually turn it over to Dr. Safdar to share her domain team update on vaccine effectiveness. Dr. Safdar, I'm going to stop sharing my screen and you can take it over.
Sounds great. Thank you so much, Usman. Let's see. I can pull up my slides here. Okay, can you see my slides all right? Yeah?
Yes.
Okay, great. So thank you very much for the opportunity to speak to the audience today about the COVID-19 vaccination domain team updates. I'll just be sharing some of the clinical questions that we think are going to be interesting and important to answer. There's a lot of work still in progress, most of which is not ready to share in its final form yet. And so we'll just take that into consideration. So we have a few projects that are ongoing in various phases of development and moving forward. Our overarching question has been to compare the comparative effectiveness of the various vaccines that have been FDA approved for preventing COVID-19 infection. We are also interested in questions 2, 3, and 4, which is COVID-19 vaccine effectiveness in preventing long COVID, the effectiveness of the vaccine in reducing or eliminating the symptoms in people who do get long COVID, and finally, the effect of comorbidities, especially different combinations of comorbidities on vaccine uptake and effectiveness. These questions have been proposed by various people in the N3C community and beyond who are interested in using N3C data to answer these questions. So the purpose of the overall vaccine effectiveness question was to evaluate real-world vaccine effectiveness with the intent to adjust for important factors such as age, gender, sites around the country, and then vaccine brands and dosage. For those of you who work with vaccine data in the EMR, there's a lot of limitations to doing that. So a lot of our work has really been trying to understand the limitations and figuring out ways to get around it. So as of April 30th of this year, the cohort description is, as you see here, that there's 3 million who are COVID positive, 25% of whom were vaccinated with at least one dose. This is probably an underestimation of the true state of vaccination, just because vaccine data does have quite a bit of missingness in it. That is being addressed, and I think over time has improved, but that is one of the limitations is that we may not know people, for instance, who were vaccinated elsewhere and that data didn't make it into the EMR for all sites. May have done it for some of the sites. And so these are the numbers for what we're finding for breakthrough infections and booster breakthroughs. So these are mutually exclusive. The breakthrough is for people who got the complete series and still developed COVID-19. And the booster breakthrough is for people who got the complete series plus at least one booster. Some may have had two and then developed COVID-19 infection. We are not quite at the point where we can say with a great degree of confidence in the accuracy of this data. We're still trying to work through to determine what the percentages will look like. So that's why this is to be considered really just as preliminary and broad strokes in our first iteration. This is also unadjusted for any of the factors that I mentioned earlier. By far, it seems that Pfizer is the preferred vaccine among the cohort in this data set. Of course, a lot of that might have to do with health systems choosing to prefer one vaccine over another, or the availability of one before the other. And so this does not necessarily mean that people had the choice of which one to take. It just happens to be the one that was the most preferred. This is work that has been published by members of the vaccine domain team that some of you may have seen, which was to examine vaccine effectiveness in people who were immunocompromised, principally HIV, rheumatoid arthritis, solid organ transplant. And this population is, of course, known to have a much higher risk for COVID-19 infection, including breakthrough. And then when they do get infection, worse outcomes from it. And so the recommendations from this group of authors was that despite having had numerous booster shots and completing full series of vaccines, this particular group who are immunocompromised may still benefit from non-pharmaceutical interventions and potentially alternative vaccination approaches. At the time that this was published, some had, but many had not received the fourth shot. And so that would be another consideration in addition to immunogenicity testing. As far as long COVID, of course, this group knows only too well what the prevalence is of long COVID after SARS-CoV-2 infection. We want to understand, and there's been some work done, of course, and published in this, potentially intriguing as in examining the value of vaccine for preventing or mitigating the symptoms of long COVID. So now we want to do this in this data set and examine to see whether it does in fact prevent or reduce symptoms or eliminate or mitigate the likelihood of developing long COVID. So this is work that is currently in progress. And so I don't have data to share on that. The same is true for the effect of comorbidities. So a number of studies have looked at what comorbidities will be at play when people get COVID in terms of outcomes. However, the effect of combinations of comorbidities hasn't been studied in any great depth. And the effect of comorbidities on vaccine uptake, I think, will be interesting to see whether there is some combination of comorbidities that makes people more or less likely to choose the vaccine over other comorbidities. So this is the current listing of project PIs. We welcome other investigators to join the team to propose questions and to work with us. This is just a snapshot of the current group that's working on things. And I'll just end by acknowledging that the slides are the work of Anup Sandamarai, who's our data scientist in the team. And along with me, the co-lead for the vaccine domain team is Dr. Jamal Matthew. And thank you to very much the members of the vaccine domain team who come forward and propose ideas and get very excited about answering them. So I will stop here and open it up for questions and comments.
I have a question. First of all, thank you. It's Ken Gersing. I really appreciate the work you're doing. More than one question. First, most of the information, and then a question. Where the CMS data is slowly coming in, and so I'm curious how that will impact what you're doing. And then the second question is, I'm sure you've worked with Emily and Richard on the 9 states or so that we think we have better data. And I'm just curious how those states help you. And third, more of an FYI, we've recently been given some money to try to work with some states to pay them to give us better vaccine data. And because we know how important this is. And I'm curious if you had, if there were states you worked with that might be interested in this project. So.
Sure. So I think the CMS data will be very helpful when it comes in terms of the completeness of vaccination and perhaps closing some of the gaps that we have. I think we have to work more closely with Emily and her group in order to better understand the 9 states that you mentioned. I haven't had those conversations myself, but Emily, you may have worked with other members of the vaccine domain team about that. But we do intend to reach out, of course, for anything long COVID related. That would be you would be the group to work with. As far as, states, so Wisconsin, for instance, where I am, is one of those states where there is a really robust immunization registry, and they do data dumps into the EMR periodically. So that, I think, from the reliability standpoint, is a good resource to have. But I don't know about others. Now that we know that there's potentially funding available, we could certainly reach out. And perhaps I could follow up with you to get some more detail about that, Ken, if that works.
Oh, that'd be great. No, that'd be great.
Thank you. Yeah, that's awesome. Thanks for that info.
I don't see any other questions. If not, then I will turn over the floor to Richard and Emily for the long COVID update. Thank you, Dr. Safdar, for your update.
So in terms of the Recover update today, we actually are going to do something a little different than we normally do. There has been a lot of great progress to report on Recover, a lot of really interesting analyses underway, including analyses around vaccinations, reinfection, and several other really important topics. We're also discussing how we can get the predictions from our long COVID machine learning model, which many of you have heard about, into the non-Recover space in N3C so that others can take advantage of that. So please stay tuned for that. But I thought that the most important thing for folks to hear about on the community forum today is actually about the Recover data enhancements, which are available for everyone in N3C to use and are now officially available. They were a work in progress up to this point, but now we have lots more data than you are used to in N3C. And much of it is from Recover, which is, we're really grateful to the sites that have participated in that. So I have asked Sofia Dard, who is an analyst at UNC that works on my team and is a stellar analyst, to present the data enhancement project, what data enhancements you can find in N3C, and how you can work with them. And then she can take any questions that you may have about how to use those data. So without further ado, I am going to turn this over to Sofia.
Thanks, Emily. Can everyone hear me?
Can hear you just fine.
Awesome. So, hey, everyone. Like Emily said, I just want to quickly and briefly go over the data enhancements that we've added as a part of the Recover effort into N3C, and also explain how to find them. So since the beginning of this year, I think around 31 sites have been working on submitting data for 1, 2, 3, or all 4 of these data enhancements that you see on the screen. And so we will talk about the long COVID specialty clinic visits first. So a lot of our sites actually have dedicated long COVID specialty clinics as a part of their healthcare system. I say a lot, but it's, I should backtrack that a little bit. It's not that many, but there are a significant amount that we wanted to include them. So we wanted to flag visits at those clinics by patients because they would be more likely to have long COVID symptoms, but also because this data enhancement helps create a long COVID phenotype with the addition to the existing U09.9 and B94.8 codes. Something that I wanted to point out was that just because a patient actually had a visit at this clinic, it does not mean that it's a guarantee that the patient actually has long COVID, but just that it would be more likely for that patient to have a lot of overlap with long COVID and potentially have long COVID. So one of the focuses that we had with some of our data enhancements was trying to make sure that the data ended up in a neat way in one table. And so luckily this enhancement fits perfectly into the observation table. So when you're looking for this data enhancement in the enclave, you can directly go into the observation table and you can actually copy paste the SQL snippet and look for long COVID specialty clinic visits this way. So a custom N3C concept ID was created to capture a visit at one of these specialty clinics, and it's given right here on the screen. So you won't have to look too hard for that. Within the observation table, you'll find a row of data corresponding to when a patient actually visited that long COVID clinic. And then the key fields will obviously be the observation concept ID, because it will contain the custom concept ID that will indicate whether or not this was a long COVID specialty clinic visit. The observation date will correspond to the day that they visited the clinic. And then of course the person ID identifies the patient, and the visit occurrence ID will hopefully tie it back to their visit. And as of just last week, we had about 8 sites out of the 31 that were submitting this specific data enhancement. I'm not too sure if, however, or how many more sites will be submitting that data, but 8 are confirmed. So before I go on to the next data enhancement, if anybody has any questions or comments, please feel free to ask, and I'll try to allow for some time between each data enhancement so that no one forgets their question.
Is this, this is Ken, is this a, it's in the observation table, is this, I guess my question is what if it was a location tape? What if it was a location? I guess I'm a little confused on why it's in the observation table, and could there be clinics that indicate other places that we aren't looking?
So Emily, you can correct me if I'm wrong, but I think sites that had this data available were specifically told to add this data in this manner. So part of the implementation guidance was to actually tag those clinic visits with this concept ID. And in our pipeline, we have this custom concept ID mapped to the observation table. So if those clinic visits are actually correctly marked with this concept ID, they will only end up in the observation table and not anywhere else.
Yeah, that's correct. And the reason that we told sites to tag them into the observation table was very specific, because we did not want to require sites to overwrite what they were currently doing in their visit table, whether that was an OMOP visit occurrence table or a PCORNet encounter table or an ACT visit dimension table. Those tables already had visit location fields that were being used for other purposes. And essentially there was no room for this extra piece of information. And for that reason, we decided as a group, it was actually a long discussion, that it would be better to put this in the observation table such that it could be linked to a visit, but is not overwriting any site's local values for visit location.
Emily, I just can't remember. Do we have a clinic locations? Are we pulling in data into that table in OMOP at all?
We do populate the location table. It is of mixed utility because not all of the common data models have space for data at that level of location granularity. So it's sort of a mixed bag.
I see. So would it conceptually though be correct to consider this? It's not a location, so to speak. It's more, you know, the purpose of the clinic, because it could be in any floor, right? So is this concept of the long COVID clinic, would it, in the ideal world, I guess, would it belong in the locations table?
I think in an ideal world it would, but because we were faced with sort of a pragmatic choice, it's not there. I do think that if we were modeling it from scratch with no concerns about overwriting existing data or repurposing a field in a way that a site didn't agree with, I think probably my first inclination would have been to put it in the location table.
Okay. And the final question is it possible that other long clinics might show up in the locations table that in sites that are using that, for instance, sites that natively use OMOP, and that we're going to have to, the people should look in two places, or will they find this information in the observation table, and they don't have to look both places?
You know, it's a good point. It is possible. I don't know of any sites off the top of my head that submit location data at that level of granularity, like clinic specialty granularity. But there's no reason that we couldn't go hunting through the location table to see if there could be other long COVID clinics hiding there. I think it's probably unlikely, but that does not mean it's not possible.
Okay, thank you.
Sure. Did you have something to add, Richard?
I was just going to say that I don't believe we required that a visit actually exist at that date in their payload to have that flag show up in the observation table. Is that correct?
That is correct. So if there is a visit there, we will link to it and it will show up, but there may be occasions where a visit occurrence ID is null. All right, Sophia, I think you can go ahead.
Perfect. So the next enhancement will be the admission discharge transfer transactions, otherwise known as ADT transactions. So we wanted to capture the movement of patients within a healthcare system, especially because we thought it was important to represent a patient's stay longitudinally. So we really wanted to be sure when a patient was in a hospital, if they were in an ICU, or if they were in an emergency department, or if they were in this other bucket of other inpatient related transactions. We also gave guidance in terms of how much of this other inpatient related transactions a site needed to submit within their payload. So we did ask sites to limit their ADT transactions to only the transfer in data. Specifically with this data enhancement, you can go look for the visit detail table, which is not a new table in the OMOP common data model, but it will be relatively new within N3C. So again, you can use the SQL snippet to get started when you're looking for this data enhancement. Those three concept IDs are not custom. They exist to identify different types of visit types. So those are the three that we ask sites to map to. So the 8717 concept ID will capture all other inpatient related transactions. And just to sort of go through a quick example so that it's a little bit easier to see, this patient is someone who was in the hospital and was admitted into the ER and then was transferred into the ICU and then was transferred into some other inpatient related service. So this is basically what this enhancement is going to look like within the visit detail table. You're going to find a row corresponding to when a patient transfers into an ICU or an ER department or an inpatient service. The key fields are obviously, when the visit happened, if it links back to a visit occurrence ID or not. And then just to point out that the visit detail source value is nulled out because we decided on not exposing that field to end users in the enclave. That is, sometimes you can sort of tell what site is submitting the data because the name of the site might be in the source visit value. And then there's about 16 sites right now that are submitting ADT transactions. Any questions?
So I'm sorry, you have 6 now?
16, sorry, 16.
16, okay.
Mhm.
I'm sorry. And is that of the 31, is that all you're going to get? Or are you expecting more?
Great question. I do not know off the top of my head how many sites we are still waiting for. I'm guessing there's a few more.
I think it's close to the full 31. It's not all 31, but there are more to come.
Any other questions? Keeping an eye on the chat too, so if someone wants to put a question there, they can. Okay, Not hearing.
I'm sorry. I'm sorry. Yeah, you thought you'd escape me.
I did.
Is there an episode ID that covers a hospitalization? So let's say John Doe, was really sick, or got inpatient, then got really sick, then got a little better, went down to step down, then went back up to ICU and down. You kind of. So there's a hospital, an episode ID that says this was all one stay. And I see, visit occurrence, or you see, but it's a different number in your thing, or is 1, 2, 3, 4 is one episode?
Yeah. So if anyone wants to add in, they can. But we are hoping that the visit occurrence ID will capture some of that episodic, I guess, nature that you're talking about. You can obviously link from the visit detail table back to the visit occurrence ID and kind of see the breakdown of a visit within the visit occurrence ID and how many separate transactions it relates to in the visit detail table. But I'm not 100% sure if every single visit detail row is going to correspond to something in the visit occurrence table.
So I think what Ken is asking for is accomplished in the macro visit logic, actually. So we have a separate table that's sort of outside of all of this, which maps individual visit occurrence IDs to single, I think episode was the word you used, Ken, to track those people who never really leave the hospital and have overlapping visits that may be hospitalizations with ED visits, or maybe even some alleged outpatient visits that happen while they're in the middle of an inpatient stay.
And Richard, I guess the question is, are you generating that episode ID to link all of those different patient movement, or is this truly an ID that we're getting from the institution?
The macro visits are a completely calculated concept that we do in N3C.
So if
looking at the patterns, yeah.
But if a person, let's say, got discharged, in the morning, whatever, 8 a.m., and then bounce back at 8 p.m., you may count that as a single episode, or would you know it's a different episode?
There are some nuances in edge cases, but in that particular case you're describing, because they share a calendar day, macro visit logic could consider smushing those two things together into one macro visit.
It would be good if we could add an episode ID, which is institution generated. And they have that because it's a billing concept, right? If that would be possible at some time in the future to add that. So Richard, you wouldn't have to do that calculation, because you would know, no matter what happened, as long as it was under that ADT, you could suck it into a single episode of care.
Yeah, I'd probably punt this one back to Emily to talk about the data models, but I think that would be ideal. I'm not sure if we'd be able to get that from all the sites.
They all have it because it's a billing concept, and all sites have a concept of an episode ID.
Yeah, the issue is that, and this is an item of contention within the CDM communities, actually, that concept is not generally supported in a CDM. And that's actually why we devised the entire macro visit algorithm in the first place. Not that the macro visit algorithm completely solves the issue for reasons that you're mentioning, but it's because CDMs in general do not really have that concept of an account the way that a source EHR would, or of an episode of care. So for example, a single pregnancy being an episode of care, that's another way of looking at it that's not supported by CDMs. So yes, you are correct that the sites have it. I don't think that there is any way, while following the rules of a CDM, for them to transmit that information to us.
Okay, Thanks, Emily. Thanks, Richard.
Sure.
Have I used up all my questions, by the way?
No, I'm sure you'll have some more questions with the next
Okay,
two.
I just wanted to know my options. Okay, go, sorry.
No, you're good. So the next data enhancement was O2 device use. So at the beginning of this year, during the initial data enhancement presentation, we spoke about vent variables and pre-respiratory support values. And since then, we've definitely had to scope down to just include O2 device use, at least just to add that specific variable into the enclave. The reason for that is because we want to at least help answer the question at any given time during a patient's stay, which O2 device was the patient placed on to receive oxygen support. And so most of these O2 device values are coming in from flow sheets from all of the sites that are submitting this data. And then we also ask them to map them locally to SNOMED codes, or one of these two concept codes that we had to create. One, because we needed a concept code for room air, which was a source value that we saw frequently within the flow sheets in response to the O2 device measure. And then we needed another concept, a custom concept for other O2 device, so that we could use that whenever we did not have a SNOMED code that we could map an O2 device to. And the reasons being, sometimes O2 devices were captured in a very granular way down to the branded name, or it was multiple devices listed on one flow sheet row. So again, we made sure that all of this data could end up in one table neatly. So this data you're going to find in the device exposure table within OMOP. This table has always been there, just probably not utilized frequently. This SQL snippet that you see will get you started. This should have most, it captures both of the custom codes as well as the 30 or so SNOMED devices and their corresponding concept IDs. So you can just plug that in and run it and see what data you get back. So within the device exposure table, one row of data is going to correspond to when a patient actually received or was exposed to an O2 device. The device exposure start date will help you determine when the exposure started. Now, the device exposure end date time, those are not required fields by OMOP, and nor did the EPIC flow sheets have a discrete stop date. So we are hoping sites did not derive it, but this is all just to explain that when you look inside of the device exposure table, the end date will most likely be null. We also nulled out the device source value, so the end user will not be able to see what the source value was called or what the mapping was, but our ingestion and harmonization team is using that source value to just make sure that the mappings are occurring correctly and to see what else sites are sending us. And then provider ID is optional within this table. So sort of as an example, hypothesis or question that analysts can look at now because of this data enhancement, as well as like the ADT transaction enhancement, is you can now theoretically look for patients that were staying in an ICU. And then you could also look up whether or not they were on a ventilator or on some form of oxygen support during their inpatient stay. So that's just something new that you could now look at. And out of all of the sites, there's about 13 sites that are actually submitting this data right now. Questions? I think I see some. Is there any way to infer the end date in certain cases? Example, a switch from nasal cannula to high flow nasal oxygen or non-invasive ventilation. So this was one of the reasons why we actually, we got some feedback from sites and we were talking internally, but because the end date did not exist, we did not want sites to derive it because we wanted to let the research team on the end user side to be able to determine how you wanted to infer this date. So if you wanted to try to see within one calendar day, if you're seeing hourly timestamps of room air, room air, room air, and then the last 5 hours in the day, you see them go to oxygen, let's say an oxygen cannula, then you could start by populating the start date of the next device use as the stop date of the previous one. But that's just one option, and that's not necessarily the best option. You would have to actually see what sort of data is being sent to be able to infer this. I think that's one of the reasons why in some of the guidance that we wrote, we also wanted to make sure that we explained that this was sort of capturing a exposure time point, sort of as like as an event. This is not the best way to capture the duration of time that a patient was on a device, but that at least at that time, you know exactly what O2 device that they were on. So when it comes time to infer things, I think it will be, you just have to be careful with what you infer. The other thing with high flow nasal oxygen cannula and like low flow, that is also something that individuals can categorize themselves, because I think high flow versus low flow, there was some discussion at the beginning of what those benchmarks would be. And I think the ranges were sort of not agreed upon per site. And I think per site, we found that what one IC department might consider to be high flow or when to switch someone to high flow was different from a different site. So I would just be careful about basically start looking at the data first and then see what you have. And then the next question is, can you reliably distinguish between basic nasal oxygen and high flow nasal oxygen? So basic nasal oxygen is definitely one of the SNOMED codes, and I'm pretty sure high flow is as well. So each site made that determination, and hopefully they mapped their local O2 devices to the best of their ability. The other things I forgot to mention was that there is actually a comprehensive list of the 30 or so concept IDs that you see here and what they actually map to. And that will be linked in our documentation tab. So that's something that you could look up to see what sorts of O2 devices we're actually capturing.
Sophie, first of all, thank you for answering all these questions. I very much appreciated. And Dave, thanks for the great questions. Another question is, are these numbers represent types of devices or actually brand names of devices? And the reason I ask that is because of another, a new 2023 super duper nasal cannula comes up. Do we need to update that, or is this a type of a device?
I would say it better fits with type of device.
Mm-hmm.
So some of these correspond to, like one of these is oxygen mask, another one is ventilator, another one is high flow nasal cannula.
Okay.
The other O2 device is what we're going to focus on, because that's where I think a lot of the branded stuff will end up, because there is no SNOMED code for something specific like OptiFlow. That was one of the branded types of things that we saw a lot of them in our flow sheets, but there was no corresponding SNOMED code for that. So sites should have mapped that one to other O2 device. And I think that would probably accurately capture any future new O2 device that just does not have a SNOMED code yet.
Okay. And then the other question is, you said these are flow sheet. Is any of this data coming in as automatic time-based data that's machine to machine? Or when you say flow sheet, does that mean hand entered? What does that mean, flow sheet?
Great question. when we were looking at this, so there are flow sheets that come directly from the device itself. And I don't think we were capturing those. These are going to be flow sheets that within, let's say they're in the ICU, you have a clinician who has just put their patient on a ventilator, and they will select the O2 device ventilator from the drop down within that flow sheet. And then within that flow sheet, there will be other metrics associated with that O2 device use. So like the O2 flow rate, other vent settings, other vent mode, things like that.
So so if in some ways a visit, this is always tough, but a visit is, John Doe came in for an outpatient. I know that's not true, but anyway, that's one type of visit. But here we could have a person with lots of different measurements within a time period, a pretty tight time period, right? Now, it doesn't sound like we're getting directly to devices, but if we were, you could imagine we could have hundreds of rows for, an hour, whatever, right? So I guess my question is, how are you all preparing? And I guess it's almost like a macro that says this is a period of time where this person's O2 spanned, because I'm wondering how our users will know how to use this, because this is, you can imagine you've had hundreds of flows, and I guess how will users know how to, it's not associated with the visit, it's kind of conceptualized this as a period of time.
Yeah, so within the device exposure table, there should be, and there is, a visit occurrence ID. So during that visit occurrence, you should be able to see like, okay, this person was in the ICU, and here's the O2 device that they were on from this device exposure table. But from there, you could still link out to the measurement table. And for that visit occurrence, can you see what other vitals were being captured? And then you could, theoretically go to drug exposure and see what drugs they were given during this time frame. So you can capture like that 6-hour window that they were in an ICU and try to paint a picture of what was happening to this patient by just joining on to other tables and kind of seeing the state of the patient. Obviously, it will still all depend on the quality of data that each of the site has sent, but best case scenario, you would even be able to link to like visit detail and see as they were transitioning between these different ADT transactions, was this patient getting worse and worse, which is why they went from the ER to ICU. And then you'd be able to see the vitals during this time frame. You'd be able to see O2 device use during the time frame, and any other metric that you would be or that you were interested in. Will it be like I almost feel like it's a jigsaw puzzle that might have a few missing puzzle pieces, but you might be able to get the broader picture with some of these enhancements and everything else that's in the enclave.
I think ideally we're going to have to come up with, it would be a visual where you would see events happening over time, over vitals, over interventions. So people can get a view of this, because it's going to be, I think it's going to be very hard. I'm just thinking ideally we'd want to come up with timelines that represent different things, and this would be one of them. Over time, you'd see vitals on one and O2 on one, and interventions and diagnosis, right? This is really just really wonderful. Great stuff.
Any other questions? Because then we'll move on to the last one. I keep forgetting there's one more. So the last question, or last data enhancement, excuse me, are the patient level social determinants of health. Are we focused on financial resource strain, food insecurity, housing status, social connectedness, transportation, stress? But just to be clear, we did not include area level variables nor does it include social history variables. Not to say that that data is not coming in some other way, but just as a part of the Recover data enhancements, we specifically focus on patient level social determinants of health. So to ensure usability, these SDOH variables were mapped to standardized codes. And in this case, we chose LOINCs. So all of our SDOH records consist of a LOINC-coded question as well as a LOINC-coded answer. Each of the sites might be collecting some, maybe all, or maybe just one of the SDOH level variables that's listed in the first bullet point. So you can't really expect all of the sites to have all of this information, but hopefully they will have some. And then again, for a comprehensive list of which SDOH variables we were actually able to find a corresponding LOINC question and answer code set to, the SDOH mappings will are saved within our GitHub data enhancement page. And so the SDOH domain team is also in the process of developing a concept set to help you find these records. Otherwise, I think our recommendation will be just to search on the LOINC-coded question. So on the right-hand side, you will see that most of the SDOH variables will end up in the observation table, but because these are LOINC-coded question and answer sets, they might also end up in the measurement table. In this example, the 370-20172 concept ID corresponds to a LOINC question, are you worried about losing your housing? And that's the LOINC-coded question bit, and then the LOINC-coded answer would be stored as the value as concept ID and within the value as string. So on one row of data, whatever question a patient was answered and whatever answer they gave will be neatly captured, hopefully, on one row. And right now, there are 13 sites that are submitting this data. So that is all of the data enhancements. If anyone has any questions about this last one. We can't see the screen. Is my PowerPoint not visible anymore?
Yeah, I can see it.
Oh,
Yes.
I'm guessing you're talking about the spreadsheet where the SDOH variables are captured, because that you can link to from here. So the documentation for all of these data enhancements, we have our GitHub link, which is the first bullet point, and that will explain with lots of details how each of these data enhancements were added into the enclave and what sites were told per CDM what the instructions look like and how they ETL this information over. And then within the N3C enclave itself, there's also a documentation page that Emily neatly created. It's going to be like a data enhancements 101. It basically covers everything that we just talked about right now. And then if you are in the past data enhancements channel, this presentation and documentation is pinned there, and you can ask questions there. And for this N3C community forum, we can also figure out how we can disseminate this presentation after the call. So you guys would have that to refer to as well.
So Sophia, really nice job to the team. One thing I wanted to ask you guys is, and I don't know if Anita's on the call, but the domain teams also have a monthly meeting, and it would be great if you could just present to them. I think this is such important information that would be really helpful, because they're kind of the disseminators to their groups, and I think that they would find this really wonderful news to have. Nice job.
Thank you.
Yeah, I think that would be a great idea if the domain teams would like to hear about this, because we want to make sure everybody's aware of these enhancements. That's part of the reason, in fact, the only reason that we wanted to use our Recover update time to present this information today, because it was really Recover that necessitated these data enhancements. But once we started getting them in, we realized how useful they would be to the N3C team in general, everybody that uses N3C. So that would be wonderful to continue to publicize this. And I want to make sure to thank not only Sofia, who's done a wonderful job with this, but there were a number of other team members who assisted with building the data enhancements, designs, and it was an enormous amount of work, including by our data providing sites, because they had to do a lot of new mappings for this. And so my hope is that these new data elements are used to answer really new and exciting questions, and that we can answer questions that we weren't able to answer before using these new data. So thanks, everyone.
Awesome. If I don't see any other questions, so I want to thank you, all the speakers for today, Dr. Safdar, Sofia, and Emily. And we'll give everybody 8 minutes back. And we'll resume our series in September. Thanks, everyone.